Good morning, everybody. I welcome all the undergraduate students. Me, Dr. Rajesh Patil, here. So, today I shall be handling you with the topic Musculoskeletal System. So, under this particular topic, we'll first deal with the normal structure, normal histology of the bone, the basic cells, the osteoblasts, the osteoclasts, of these the precursor osteoclast cells, the bone forming cells, and then into certain benign lesions of the bone, could be like osteomyelitis, the inflammation, or the osteoporosis, the age related ones, and few benign lesions of the bone we shall study. So starting with this particular topic, what are the basic functions of bone? Mechanical support, transmission of forces generated by muscles, protection of viscera, mineral homeostasis. There's an important point here, mineral homeostasis, and providing a niche for the production of blood cells. So basically the bone marrow, we call it as a factory for cell production. So these are the basic functions of the bone. So basically it consists of matrix and cells. Now what does this bone matrix is made up of? The organic component known as osteoid, that is 35%, and a mineral component, that is 65%. Matrix is synthesized in one of the two forms, the woven bone and the lamellar bones. Okay, this is how the matrix is. Now what are these particular cells? The osteoblasts located on the surface of the matrix synthesize, transport and assemble bone matrix and regulate its mineralization. Osteocyte located within the bone control calcium and phosphate levels. Osteoclasts, so osteoclasts are very important even when it comes to viva question or a 3 marks question. Located on the surface of the bone, multinucleated macrophages derived from circulating monocytes. So these are basically the derivatives of monocytes, the monocyte macrophage system, which are responsible for bone resorption. So this is the picture, the histological section that's normally showing these particular osteocytes, osteoblasts, the osteoclasts, the giant cells, these particular giant cells, the osteoclasts here. Development. Long bones develop from a cartilage mold by the process of enchondral ossification. Okay. So the intramembranous ossification by contrast is responsible for the development of flat bones. See the stromal cell, the osteoblast with that particular receptor, and the osteoclast precursor cells in between there with the binding with this particular ligands, the receptors, and how the bindings takes place and the differentiation of these particular cells. And there's osteoclast adherent to this particular bone there, the schematic diagram. What are the congenital anomalies? Abnormalities in a single bone or a localized group of bones are called dysostosis and arise from defects in the migration and condensation of mesenchyme. They manifest as absent, supernumerary, or abnormally fused bones. The global disorganizations of bone and cartilage are called dysplasias. So these are nothing but the disorganized bone. So bone disorders can be basically divided into developmental one, infectious one, metabolic, and tumors. So tumors will be dealing in at the last part. Developmental: achondroplasia, thanatophoric dysplasia, osteogenesis imperfecta, osteopetrosis, mucopolysaccharidosis. Now, what do you mean by achondroplasia? It is the most common skeletal dysplasia and a major cause of dwarfism. The autosomal dominant disorder resulting from retarded cartilage growth. The disease is caused by gain of function mutations in fibroblast growth factor receptors. So the normally fibroblast growth factor inhibits enchondral growth. So FGFR3 mutation results in a constitutively active receptor, thereby exaggerating this effect and suppressing growth. Now, what do you mean by thanatophoric dysplasia? The most common lethal form of dwarfism results from diminished proliferation of chondrocytes and disorganization in the zone of proliferation. It also is caused by gain of function mutations. The features: micromelik shortening of limbs, frontal bossing, relative macrocephaly, a small chest cavity, and a bell shaped abdomen. Now, coming to type 1 collagen diseases, that is osteogenesis imperfecta. The most common inherited disorder of connective tissue is a phenotypically diverse disorder caused by deficiencies in the synthesis of type 1 collagen. Affects bone and other tissues rich in type 1 collagen, that is joints, eyes, ears, skin, and teeth. Autosomal in the genes that encode alpha 1 and alpha 2 chains of type 1 collagen. Osteopetrosis, also known as marble bone disease, refers to a group of rare genetic diseases that are characterized by reduced bone resorption and diffuse symmetric skeletal sclerosis resulting from impaired formation or function of osteoclasts. Osteopetrosis reflects the stone-like quality of the bones. However, the bones are abnormally brittle and fracture easily like a piece of chalk. Most of the mutations underlying osteopetrosis interfere with the process of acidification of the osteoclast resorption pit, which is required for the dissolution of calcium hydroxyapatite within the matrix. These include autosomal recessive mutations in the enzyme. So these are the intricate things that you should be aware of. The CA21, TCIRG1 gene, the involvement of these. Bones involved by osteopetrosis lack a medullary canal and ends of long bones are bulbous. Now infections, this is important even from the exam point of view. The osteomyelitis. So 5 marks question or a 3 marks one. Osteomyelitis denotes inflammation of bone and marrow, virtually always secondary to infection. It may be a complication of any systemic infections, viruses, parasites, fungi, and bacteria. So any of these infections caused by these organisms can yield to osteomyelitis. Infections caused by certain pyogenic bacteria and myobacteria are the most common. Pyogenic osteomyelitis, almost always caused by bacteria and rarely by fungi. Organisms may reach the bone by hematogenous spread, extension from a contiguous site, and direct implantation after compound fractures or orthopedic procedures. Occur most commonly in the long bones of infants and young children, particularly in the developing countries of the world. Staphylococcus aureus is implicated in a vast majority of cases. Less common causative agents: Streptococci, E. coli, Pseudomonas, Klebsiella. So all these gram-negative organisms can also cause them. Mixed infections, especially in case of post-traumatic cases of osteomyelitis. So this is how sinus tract formation in these particular cases. You can see that the pus formation, the abscess at the center of the core in the marrow, surrounded by is the cortex, skin, lamellar bone, the marrow space, articular cartilage, the epiphysis. So at the center, the red one, you can see this particular, the abscess formation. So drainage of this red color at the center, that is abscess outside into the skin, the draining out, that is the draining sinuses. So these schematic diagrams are very much needed when you write an answer. So this is again the gross picture, the abscess formation and the draining sinuses. Clinically, child with acute hematogenous osteomyelitis has painful and tender limb. Fever, malaise, leukocytosis generally accompany the bone lesion. Radiologic examination confirms the bony destruction. Chronic suppurative osteomyelitis. Histologic appearance shows necrotic bone and extensive purulent inflammatory exudate. So a lot of inflammation. So presence of clusters of neutrophils and the necrotic debris indicates it's an abscess. The pus, that is suppurative inflammation. Complications: septicemia, the most catastrophic one. Acute bacterial arthritis, pathologic fractures, development of squamous cell carcinoma, the most dangerous one in long-standing cases. Secondary amyloidosis. Vertebral osteomyelitis may cause vertebral collapse with paravertebral abscess, epidural abscess, cord compression, neurological deficits. Now, tuberculous osteomyelitis. Such schematic diagrams are very much essential. See that vertebral bodies are destroyed with formation of tuberculous abscess there at the center, the pus extending into the disc. So intact vertebra, prolapsed disc, the pus draining on the. So this is formation of the Cox spine. Caseation necrosis, epithelial granulomas, Langerhans giant cells, necrotic bone. All these are the hallmark in the microscopic findings, the histology of such sections. Coming to metabolic and endocrine bone diseases, important one. Osteoporosis resulting from quantitative reduction in otherwise normal bone. Osteomalacia and rickets characterized by qualitative abnormality in the form of impaired bone mineralization due to deficiency of vitamin D in adults and children respectively. Scurvy caused by deficiency of vitamin C resulting in subperiosteal hemorrhages. Hyperparathyroidism leading to osteitis fibrosa cystica. Pituitary dysfunctions, hyperpituitarism causing gigantism and acromegaly, and hypopituitarism resulting in dwarfism. Thyroid dysfunctions, hyperthyroidism causing osteoporosis and hypothyroidism leading to cretinism. Renal osteodystrophy occurring in chronic renal failure and resulting in features of osteitis fibrosa cystica, osteomalacia, and areas of osteosclerosis. Skeletal fluorosis occurring due to fluorides. So this is one the fluorosis wherein the content in the water of fluorides is more. Osteoporosis, osteopenia. So this is decreased bone mass. The osteoporosis, osteopenia that is severe enough to significantly increase the risk of fracture. So fractures are very much seen in a patient with osteoporosis, that is old age or 50 plus. It can be localized or generalized. It can be primary or secondary. The most common forms of osteoporosis are the senile and postmenopausal types. Pathophysiology, the flow chart, again important one. The genetic factors, nutrition, physical activity. So good nutrition with good physical activity is very much essential for increased density of bone. So less chance of fracture. See, aging, menopause. What does aging do? Decrease serum estrogen levels. Increase interleukin 1, interleukin 6, TNF. Increase expression of this rank. Increase osteoclast activity. Aging, what does this cause? Decreased replicative activity of these osteoprogenitor cells, decreased synthetic activity of osteoblasts. So all these cells, the activity is reduced. They are a bit inactive. Decreased biologic activity of matrix bound growth factor, reduced physical activity. So leading to osteoporosis. See this. These particular bones, they are just looking like very fragile. They are looking like brittle. See, a lot of spaces. It's not dense solid. It is porous. Morphology. The hallmark of osteoporosis is histologically normal bone that is decreased in quantity. The entire skeleton is affected in postmenopausal and senile osteoporosis, but certain bones tend to be more severely impacted. In postmenopausal osteoporosis, the increase in osteoclast activity affects mainly bones or portions of bones that have increased surface area, such as cancellous compartment of vertebral bodies. The trabecular plates become perforated, thinned, and lose their interconnections, leading to progressive microfractures and eventual vertebral collapse. Clinical features: vertebral fractures that frequently occur in the thoracic and lumbar regions are painful, and when multiple, can cause significant loss of height and various deformities, including lumbar lordosis and kyphoscoliosis. The immobility following fractures of the femoral neck, pelvis, or spine results in complications such as pulmonary embolism and pneumonia. Investigations. So, osteoporosis cannot be reliably detected in plain radiographs until 30 to 40% of the bone mass is lost. So, plain radiographs usually miss it. Measurement of blood level of calcium, phosphorus, and alkaline phosphatase are not diagnostic. Okay? They can give you a clue, but not thoroughly diagnostic. Specialized radiographic imaging techniques such as dual energy X-ray, absorptiometry, and quantitative computed tomography, both of which measure bone densities, important one. So measurement of bone density is very important. So less the bone mass, the osteoid mass, the more porous is the bone. In advanced osteoporosis, both the trabecular bone of the medulla and the cortical bone are markedly thinned out. Now, treatment: exercise, appropriate calcium and vitamin D intake, and pharmacological agents such that decrease resorption. Biphosphonates reduce osteoclast activity and induce osteoclast apoptosis. So these are certain drugs there. Osteitis fibrosa cystica, hyperparathyroidism of primary or secondary type, results in oversecretion of parathyroid hormone, which causes increased osteoclastic resorption of the bone. Susceptibility to fracture, skeletal deformities, joint pains, and dysfunctions as a result of deranged weight bearing. The bony changes may disappear after a cure of primary hyperparathyroidism, such as removal of functioning adenomas. The chief biochemical abnormality of excessive parathyroid hormone is hypercalcemia, hypophosphatemia, and hypercalcemia. Grossly, there are focal areas of erosion of cortical bone and loss of lamina dura at the roots of teeth. Earliest change is demineralization and increased bone resorption, beginning at the subperiosteal and endosteal surface of the cortex and then spreading to the trabecular bone. There is replacement of bone and bone marrow by fibrosis, coupled with increased number of bizarre osteoclasts at the surface of moth-eaten trabeculae and cortex. As a result of increased resorption, microfractures and microhemorrhages occur in the marrow cavity, leading to development of cysts. Hemosiderin-laden macrophages and multinucleate giant cells appear at the areas of hemorrhages, producing an appearance termed as brown tumor. So this is a viva question again and a 3 marks one. Or a reparative cell giant cell granuloma of hyperparathyroidism. So we'll skip this one. So these are the gross and microscopic features. Renal osteodystrophy, usually iatrogenic. Renal dialysis and transplant increased survival with ESRD, and there is development of bone diseases like osteodystrophy. There is abnormal calcium and phosphorus metabolism, and they develop early, but symptoms are delayed. What is the clinical features of this renal osteodystrophy? Bone pain, muscle weakness, pathological and distress fractures. So this is again the flow chart. The decreased GRF, decreased phosphorus excretion, hyperphosphatemia, decreased calcium, increased parathormone, secondary hyperparathyroidism, leading to increased osteoclastic activity. The histopathology, 3 major types. That is high turnover one, that is secondary hyperparathyroidism with tunneling resorption, increased osteoclastic activity, hyperosteodosis, irregular arranged osteoblasts, tetracycline labeling, bone formation, osteosclerosis, marrow fibrosis. So there is paratrabecular fibrosis, osteitis fibrosis, and then low turnover, that is osteomalacia. Occurs after commencing dialysis in 5 to 25% cases, shutdown of parathyroid activity as a result of treatment, decreased osteoclastic and osteoblastic activity, decreased resorptive surface, tetracycline labeling decreased, wide osteoid seams, increased mineralization, so mixed type. So all these are again the gross features and the cut features of this particular bone, the cut sections. So you can see all these particular activity, the low osteoclastic activity, loss of trabecular bone and bony sclerosis are the features here. Marked osteoclastic activity and deficient mineralization. So there is again right side Van Giesen stain showing osteoclastic resorption and osteoblastic new bone deposition. The radiology, more pronounced than primary hyperparathyroidism, subperiosteal and subchondral bone resorption, earliest tufts of distal phalanges, radial aspect of middle phalanges, osteosclerosis, Rugger Jersey spine, alternating areas of sclerosis and porosis, the brown tumors, that is well defined lytic lesion usually in metaphysis. So that is called as a Rugger Jersey spine here. The loser's lines. So viva question. They can ask you what is Rugger Jersey spine, where you see it. So you should be aware of that, alternating areas of sclerosis and porosis. So by this we conclude this particular class. So meet you soon in the next class. Thank you.